Hello and welcome to the COMLEX Instant Review. Please visit comlexflashcards.com for complete COMLEX prep resources. That's comlexflashcards.com. Let's review hemochromatosis. This is an autosomal recessive disease of iron absorption, and there's excessive iron absorption in the intestine, which leads to increased accumulation of iron as ferritin and hemosiderosis in various organs. Over the years, fibrosis is involved in organs, and this occurs secondary to hydroxyl free radicals that are generated by the excess iron. And it's an inborn iron of iron metabolism, and again, the eventual fibrosis and organ failure can lead to cirrhosis, cardiomyopathy, diabetes, and hypogonadism. Understand that this is an autosomal recessive disease. There's an association with the hemochromatosis gene, and it's the most common single gene disorder. Also, the C282Y/H63D compound heterozygosity has been a key factor in hemochromatosis, where you have a cysteine to tyrosine substitution. There is an iron overload primarily in this disease, and the net absorption of 3 to 4 milligrams per day is changed, whereby you have an accumulation of 500 to 1,000 milligrams iron per year. And the clinical manifestations often occur after 40 or when stores are between 50 to 40 grams. In terms of the clinical features, keep in mind that secondary hemochromatosis can occur with multiple transfusions or in chronic hemolytic anemias. Most patients are asymptomatic initially, and findings may include signs of liver disease, fatigue, arthritis, impotence, amenorrhea, abdominal pain, and cardiac arrhythmias. Patients also have been influenced by their age, sex, dietary iron, alcohol, blood loss in menstruation, pregnancy, and again, associations with alcohol abuse and hepatitis C can accelerate the disease. The classic description is the cutaneous hyperpigmentation and diabetes in a patient with cirrhosis. The reversible manifestations include cardiomyopathy, conduction disturbances, abdominal pain, elevated LFTs, hepatomegaly. There is bronzing of the skin due to melanin deposition, gray pigmentation from iron deposition, and Vibrio vulnificus, Listeria monocytogenes pasteuralis have all been associated with hemochromatosis. In terms of the irreversible manifestations, you have cirrhosis, and cirrhosis increases the risk of hepatocellular carcinoma by 200-fold. The presence of liver disease is a primary factor in determining the prognosis. Patients have gonadotropin insufficiency leading to secondary hypogonadism. There's diabetes mellitus, hypothyroidism, primary hypogonadism, and arthropathy in the MCPs, as well as pseudogout are common associations. Understand that homozygosity is as common as in men, and what happens is that the presentation in women is a little bit later because of the physiological blood loss in women and higher iron intake in men. So there's a special scenario in women, and it presents slightly differently. To make the diagnosis, you have to have markedly elevated serum iron and ferritin levels. There's elevated iron saturin, which is the transferrin saturation, near 100% and usually above 60. There's decreased iron, total iron binding capacity, and a liver biopsy is required for diagnosis. And again, genetic testing for chromosomal abnormalities is also commonly done. So to review, there is elevated serum transferrin saturation greater than 45% and an elevated serum ferritin. And the gold standard is the liver biopsy. To treat hemochromatosis, you have to understand that performing repeated phlebotomies, this is the treatment of choice, and that improves survival dramatically if it's initiated early in the course of the disease. Also, treat any complications such as CHF, diabetes, hypothyroidism, or arthritis, and consider liver transplantation in advanced cases as well. Again, the key thing here is phlebotomy and avoiding alcohol, raw seafood, iron supplements, and red meat. Phlebotomy is generally done to remove 250 milligrams of iron, and again, some of the indications to completing phlebotomy include hemoglobin less than 120, ferritin less than 50, and transferrin saturation less than 50%. And this is a long-term therapy. for genetic testing, point mutations at C282Y and H63D are generally considered, and again, genetic testing is not recommended in less than 18-year-olds, and keep in mind that this is just one of the other options. For screening, currently screen patients who have chronic liver disease, signs and symptoms of the disease, or a family history of iron overload. Again, this was a review of hemochromatosis. We reviewed the definition, the treatment, and the various causes of hemochromatosis. And there's a classic triad of micronodular cirrhosis, pancreatic fibrosis, and skin pigmentation that's seen in hemochromatosis. Please visit COMLEXFlashcards.com for complete COMLEX prep resources as you prepare for the COMLEX board exam. That's COMLEXFlashcards.com for your complete board prep resources. Good luck in your preparation for the board exam.